I was having dinner with Sue one evening when she's asked me for a potential topic for this symposia, and the best that it came up to mind was the recent study that had been presented at American Hematology Society last year on the effect of driving distance between home and transplant center on outcome that have been done by the Dana-Farber Cancer Center, and that's what we are going to review. We'll first review that study, and then Dr. Fernandez will discuss each of the potential implication to this study. So Karim Abu Nassar is the primary investigator. Philippe Ormond is the senior investigator at Dana-Farber that have done the work. But previous work actually have been done in this area by investigators at Nebraska. And I found that living away from the transplant centers limits access to medical care, decreases the care after transplant, and causes worse outcome. So in these two studies, what they looked at actually was mostly autologous transplant for lymphoma, and I found that in patients that were living in rural areas, as defined by the density of population in their particular area, had worse outcome. And this was related to the increased relapse after transplantation. So the survival at 5 years of patients receiving autologous transplant, most of these for lymphoma, was 54% if treated in if the residence was in urban area versus 48% in rural area. They had a small subset of patients that received allogeneic transplant, and that particular analysis didn't show a great effect. I mean, it didn't show a significant effect. So the fact that rural residents had worse outcome after autologous transplant for lymphoma may suggest that they either had not received appropriate therapy before transplant, or that we're not conducting timely monitoring after transplant, because obviously 5 years is quite a bit of time after autologous transplant for lymphoma. The questions that the Dana-Farber study addresses are about geographic proximity, and they address mostly whether this affects the frequency of the visits to the transplant center. You would expect that somebody that lives nearby may be more frequently visiting with physicians at transplant center. And the other major question is whether it affects the outcome of an allogeneic transplant. And included in these studies were adult patients. Those that had received the first allogeneic transplant were treated at Dana-Farber Brigham and Women's Hospital between January 1st, 96 and June 30th, 2009. Patients that were excluded were those that were leaving outside USA, and those that were leaving greater than 6 hours driving time from the transplant center, because it was thought that those were going to go and have follow-up mostly at local transplant centers. Up in the Northeast, there are so many transplant centers that obviously patients have much more of a choice than they have over in the Southeast area of the United States. And the way that they've done the work is they have merged the data from the allogeneic transplant clinical database from Dana-Farber and Brigham's with the clinical operation database that include the zip codes of the patient's residence and their visits to the transplant center. And they have used a program that will allow to geocode the residence of origin and figure out what the routing was to the transplant center in Boston and calculate the distance. And so the first question was, does the geographic proximity influence the frequency of the clinic visit? And so what you see here is the number of minutes. If it was less than 40, you were looking at visits between day 100, which usually is the time when patients are released from transplant center proximity back home, until day 365, and they had 14 visits, which is about almost 2 visits per month, basically. And then if you go between 41 and 159 minutes, 40 and 2.5 hours was 11, which is still a little bit more than 1 per month. And then those that were greater than 160 minutes were 8 visits, which is a little bit less than 1 a month. Obviously, there are ranges. There's somebody that was never seen. So this very significant difference. So patients that have to drive more tend to go less frequently to the transplant center. Presumably, they are getting blood draw at LabCorp or Quest or other local laboratories, or just go see their own private oncologist or hematologist. Here the transplant physician a little less often. When the analysis for survival was run, looking at time from transplantation, there was a suggestion that those with greater distance had worse outcome, but really they were not different statistically. Once we compare outcomes, we need to have statistical rules, because if there are small differences, they may occur just by chance. The problem, though, here is that most of the events were occurring within the 3 months, and many events were occurring within the first 3 months when patients really are at the transplant center, whereas the effect that we were trying to analyze here was the effect of geographic distance. And so what the investigators did is actually did a landmark analysis, meaning they just analyzed those patients from 12 months on, those that were alive at 1 year. And here it was clear that those patients that had to drive more than 160 minutes had worse survival. And this is about 15% point. So it is quite a bit of difference given everything we do in transplant. Major advances in transplant have been able to improve outcome by almost as much, not nearly as much. So what you see is that there is a grading 0 to 41 at the best survival, and then 42 to 160 minutes, the survival is intermediate, and the greater than 160 was the longest. Now, obviously, these are just arbitrary separations. They're not true breakpoints, but the concept is the closer the patients were to the center and the best the survival. And this was an analysis that looked at the relationship between number of visits between 100 days and 365 days, and survival counting from 1 year. Obviously, those patients that have an intermediate number of visits, that they're well, presumably didn't need very many visits, actually did better than the others. But those that have very few visits, or those that have very many visits, did worse. And those that had very many visits, presumably because they had more need for them, but the ones that are remarkable here is those that had 0 to 6 visits, which is, again, gets to less than 1 a month, actually had quite a worse outcome. So what this study shows is that patients living, well, actually the Nebraska data showed that patients living in rural areas have lower survival rates after an autologous transplant. Predominantly that was because of increased rate of relapse, either because the treatment was not provided as aggressively before the transplant, or because post-transplant follow-up was not as rigorous, and perhaps the disease relapsing was not caught at the first initial sign, when there is still quite a bit that we can do. Patients drive in the Dana-Farber study, patients that are driving a long distance to the transplant centers have worse survival rate after allogeneic transplant. And the effect of driving time on survival appears after 12 months, so it's not immediate. It takes a while. You know, if the patients have complications, it takes a while for them to generate, to become, untreatable. This effect is independent from other factors. I haven't bored you with lengthening statistics and what in evidence-based medicine is called multivariable modeling, but taking into account all the factors that we usually look at in transplant outcome, the investigators couldn't find that distance from residence to transplant centers was confounded by anything else, was independent. And it was due to actually causes other than relapse. So this was due to transplant-related complications. The lower frequency of the visit may contribute to the lower survival in patients that are living farther away. I leave you at that. We'll have Dr. Fernandez go on to the discussion, and then we'll have the overall question session.
Okay, so my portion of this is actually a two-part process. One, I will be talking a little bit about these factors that affect us post-transplantation. Also, I gave you a little homework to do. And give us some information on your experience post-transplantation and how well you've been versed in the issues that could happen post-transplantation. Because, my first aspect of this is, why are we doing this exercise? I think there's a gap here. I know there's a gap here. And we're trying to narrow this gap and try to get the information here. So are we doing a good job of getting you ready for the post-transplant experience, hooking you up with the proper information, the sort of lifelines of getting back to us at the center? Are we communicating well enough with you, making sure that you have the avenues back to us if necessary? Because if distance does make a difference, does communication back and forth make a huge difference? And we need to know how to figure out how to do that a little bit better. Are you understanding the information that you're getting to as you're being bombarded with? You're going to get transplant, you're going to get graft versus host disease, acute graft versus host disease. You have to worry about infections. But then once we let you out of our little ring of confidence here, you have to be within a certain time of the center. Once we let you go back home, are we giving you enough information on what's going to happen later about not only your disease health, but your post-transplant health? And the other question here, and this is where I want to lead the discussion, is, are we being proactive or reactive to what's going on? Yes, you get a symptom, you call us, but are we dealing with things ahead of time and maybe preventing some of the problems ahead of time? I see some shaking heads, and I like that. That's okay. This is all good. So why have the follow-up at all? I mean, transplant should cure the disease, correct? But there's still some disease that comes back, so disease surveillance is important. And should we be getting it more frequently than we are getting it? We have medications that you have on board that if you take for the rest of your life they'll probably limit your life because they're going to cause other side effects, and they may cause infections and other issues. So we have to reduce that, and we have to do it appropriately. If we do it too fast, graft versus host disease comes on board, or if we leave it on too long, we could have the disease come back. So all of those are issues. And are we dealing with some of those later transplant toxicities, not only from the chemotherapy and radiation therapy that you've received, but also from the medicines that you're on chronically? And are we doing a good process and health evaluation post that? not only with the transplant complications, but with just general health overall, osteoporosis, osteopenia, issues with endocrine function post-transplantation, and we're going to get through some of those. We know patients call us back, and particularly when you have specific issues. And are you calling us, or are you calling your primary physicians on these issues, particularly the graft-versus-host disease that you know about in the early part with the gut, the skin, and the liver? We talked to you about that ad nauseum. And some of these can happen after those first 100 days in the center. But then what about the chronic issues, the dry eyes, dry mouth that occurs, issues with the lungs and or the joints, the skin, or endocrine problems or other problems that can happen afterwards? With the infections that occur and the surveillance of the infections that can occur, the cytomegalovirus infections, the Epstein-Barr virus infections, any of these things that can happen later on that you may not really hear much about other than the fact that you know that they may occur. Again, getting back to the bone issues, the osteoporosis, osteopenia that can occur after this, and are we doing well enough from that standpoint? How about avascular necrosis, which is that sort of dying bone that occurs because of steroids or because of trauma during the transplantation? And then are we dealing enough with the endocrine problems, particularly the sugar, the hormones, and your thyroid function after transplantation? And are we doing the right things from that standpoint? Are we doing it? Are the physicians at home doing it? And these are questions that need to come up. We know we provide you with information at the time of discharge. We give you your medical records. That's what's happened to date to fill in the physicians at home. We tell you which testing needs to be done, and then we give you our contact information, and then we set up the follow-up, and the follow-up may vary. It may be, if you're having some issues, a little closer, but if you're doing well, will we see you back in 3 months, or will 6 months, or even a year? Those are questions, and what is the right amount of follow-up? As Dr. Anasetti presented to you, it's sort of the Goldilocks. You don't want too hot, too cold, but you want it just right. And we need the right amount of follow-up for you so that we can do this correct. And then what are the pros and cons of having your health care at home versus in your BMT home? Your home, you don't have the BMT experience that you have at a BMT transplant center, but you got a better focus on general health, as the transplanters may be more focused on the disease and the GVHD issues, but not the other aspects that occur. At home, you have a significant amount of support. You have your family support, friend support, work support sometimes, and we were stripping you of that for you coming into the transplant center and not be able to go get those issues. And then finally, the financial aspects of being at a transplant center versus being at home. Some things may be paid for while you're at home versus a transplant center. The ability to work and those issues need to come forward to us. So, you have to balance all of these things. Where's the best place to get all this performed, and can it be done, and is it being done correctly? And those are part of the questions we have as we go along here. So the other issues that occur are insurance restrictions here. Do you have to have it done at home, or do you have to have it done at the transplant center? What's going to be paid for? What's not going to be paid for? We have to calculate the issues of distance and travel and the costs of that. I think we on our side, we kind of ignore it. We expect you to be here, but that's a great strain and a great burden to the families here. This issue of relocation, albeit be it for 3 months or be it for a couple of days or 1 day to come back and get your testing done. And then the emotional distress of coming back to the center, it's sort of a little nostalgia and a little pain otherwise. So, those issues do come up also. We have insurance issues. Sometimes there's unlimited care, and it's not a problem. Sometimes it's limited from the time of transplantation to a certain date, and then you're done. And then where do you go from there? We know that the funding, as you get farther out, becomes a little bit more restrictive. And then there's also the issues of losses of insurance, either due to work stoppage or other issues. Some people cap out their maximum medical benefits over time because of transplantation and the costs associated with that. So this is the information that we would want to know. We also want to know the distance from your center, whether you're just around the corner, are you a little farther out, are you really far out, or are you basically just coming in because the center is an expert center? I mean, some people travel across the country, and particularly in the older days would go all the way to Seattle. Now, pretty much you can have it in your backyard, but we can't have a transplant center everywhere, and everybody can't be 30 minutes from a transplant center because it's just not realistic. So what is the right amount? How do we get this, and how do we network a little bit better so that you feel a little safer and then have that safety net for you? Again, with the travel costs, the lodging, the meals that occurred with that, if airfare or gas, and we're getting pretty close these days, so one has to consider one versus the other in getting to the place. And then the issue of work stoppage and loss because of these visits, and obviously we have to look into child care as you're coming forward to us, who's going to take care of the kids while I come visit the center again, and these have to be brought into light. And then finally, the emotional distress, the retesting, the bone marrow biopsies, the scans, because most people tell me, I sleep great except the night before I come to see you. And I'm starting to take it personally, but I understand there's other things that are going on here. This concern about coming to see the doctor, maybe avoiding the doctor because they know, well, we may have to hospitalize you again for this or that or whatever. And, I didn't think this rash was a big thing, and so I was going to ignore it and not tell you about it, but now you saw it. And then, yeah. And so we find things and saying, how long has this been going on? And it's like, uh-oh. And then obviously this fear of bad news, whether it be from the GVH standpoint or even the disease standpoint, and bringing those issues. So we have a survey here, and it goes into some of these issues post-transplantation. I want you to think about these issues. Dr. Anasetti presented issues on survival. But what is the why of the survival? Why are people? Is it because of relapse disease as within the autologous setting? It didn't seem to be that so much in the allogeneic setting. So it then comes back to these issues of graft-versus-host disease, infection, and other medical issues that pop up post-transplantation, which can be a huge problem. I'll give you an example. If somebody misses a lab, let's say a liver function, and it's slowly creeping up, and then suddenly, boom, you're in full-blown graft-versus-host disease, can that take somebody's life? Or is there an infection that somebody thinks, it's not a big deal, it's just a cold sore, it's just a little cold, but and we lectured to you that colds can be very important in somebody post-transplantation, also depending on how much immune suppression you're on. So all of these are things that we're going to discuss now and kind of bring forward, and this is your chance to voice. This is your chance to tell us, you're doing this right, you're not doing this right, you guys doing it well, but my guys at home are not doing it well. What are the issues that you face? And this is really where the rest of the time here, and we've got a good half hour here to really let loose and bring it wide open. So I'm actually going to relinquish the floor to you. There is a microphone in the center. This is being taped, so we do want you to come, ask your questions, and tell us what's right, what's wrong about this, what's been missed in the past. Give us examples of things that could have been done better or should have been done better, or maybe you think should be done better. They're doing it okay, but maybe we can bring it up a notch or two from that standpoint. And also I want you to fill out those surveys and bring them forward, and I will now relinquish the floor to you folks.
I think that this brings back to what Bob Batty showed at his keynote speech this morning, a plan of summary of the treatment that was delivered and a survivorship plan. When I first came to Moffitt, I started to think that what we needed to focus on was the first 3 months, get the patient well, and start connecting with the referring docs. So expand our network, expand our communication system. But really throughout all Florida, we have about 600 referring docs, and probably 2 feel comfortable in managing immune suppression. So the rest really don't. And so rather than actually setting up that type of network, what we really need to do is getting assistance to get the patients back. And in the beginning, I thought perhaps then I'll care for patients until they're on immune suppression and then let them go. But then even those patients that are off immune suppression are still at risk for hypothyroidism, secondary cancers need surveillance. And so I think that that's absolutely a need. The other issue is that Cancer Center-wide, we have a survivorship clinic. Patients that have been disease-free for 5 years can actually have a yearly checkup that basically deals with multiple organ surveillance. But what I found is that our transplant patients don't like to go to that clinic because they're actually connected to our team, and they feel like they don't need to spend 4 or 6 hours traveling from all over Florida to actually go to that particular clinic. They want to come to see us. So I don't know whether you have a point of view on that one, because that's an issue and really helpful to know.
How about other persons' experiences? In particular with their local physicians versus the BMT? Are there experiences that have worked out well, have not worked out well? How much communication is occurring? Please come forward. Well, I think this is part of the problem here. It's how much is too much and how much is too little. We brought you these issues that weigh on you coming back to Emory, but it's obvious here that there are some symptoms here that you're having that your local physician is not regarding as associated with the transplantation because they're not sure of it. And we see this all the time. Things such as fatigue. Things such as, they attribute, you're getting old, or you're depressed, or you're this, and most of the time it's a slight manifestation of the graft-versus-host disease, but it's there, and people are not aware of that, and we're still refining how to diagnose it, how to measure it, how to make sure that it's something that maybe you do need some therapy for that. Do you need some local therapy, or do you need some systemic therapy? And those are the questions that a transplant center should be. And it's probably it's interesting to find out how everybody does things a little bit differently. Again, the old Seattle model, since most people were traveling from the country, was to treat them the first 100 days and send them back, and they'd see them periodically once, a year, every 2 years, but in the meantime, they're this big packet they sent to the oncologist or hematologist that's treating them and say, this is what we want you to do, this is what you want to look out for, and check the boxes and, send us this information periodically. And in essence, it is some follow-up, and maybe there's some idea of what's going on, but the standard primary physician will probably not know anything about graft-versus-host disease. The hematologist and oncologist probably remembers what they had during their fellowship at most, and that's the extent of it. But then they're really not sure. They're looking for the diarrhea and the skin changes and the liver abnormalities, but beyond that, they really don't look. And these are problems that I think can be and should be talked about with your transplant center. Now, the question is, do you have contacts in the transplant center that you can speak to or call if you have issues?
Well, I went back to 5 years.
Well, I mean, there are therapies, again, and it depends on how much of scarring of the salivary glands that you have. And, again, with the lacrimal glands for your eyes, it depends on. So there are some sessions on some of those issues, and you should go to those. But it's probably very realistically to say you're going to get back to where you're not on anything for any of these. It's probably unlikely at this point in time.
You started to have dry mouth and dry eyes at 2 years after transplant. Now it's 3 years ago, and
6 years ago.
Yeah. But it's 4 years that you've had these symptoms. You've been on no immune suppression.
No.
Right. Right, and you have no other symptoms of graft-versus-host disease. So what you have now are symptoms of spent graft-versus-host disease that's made a damage in the salivary gland and the lacrimal glands, and as much immune suppression as we would give, that would not reverse it. So what you can do is basically supportive therapy. The anticholinergic drug, cevimeline, is actually Avoxac, a brand name. Is probably the one the patient likes the best from point of view of mouth dryness. And then for the dry eyes, ligation of the ducts is done, so that basically what you do is that you have kind of a faucet in the eye. You plug the hole in the faucet, the drain, and so that the little tear that you make stays there longer. The anticholinergics don't work very well for dry eyes. And then if the disease is very advanced, there are other procedures that can be done at specialized centers, basically. But those are the ground approaches to dry mouth, dry eyes. Now, if I had heard from you, had seen you in my clinic at 2 years after transplant with those symptoms, would I have given you additional therapy? Based on what I know now, using blood stem cells that cause so much more graft versus host disease and so much more protracted graft versus host disease, I would have probably put you back on a little bit of immune suppression and taper it much more slowly. Whereas, we were tending to keep patients on immune suppression for 6 months in the beginning with bone marrow transplants, and they worked with siblings about half of the times. With unrelated donor only worked about 20% of the times. With peripheral blood stem cells, it works basically never. And so we just need to change our treatments because of the different type of treatments, transplants that we do now. Those are the issues. So, but getting back to the overall theme of the session, patients that go to their local physicians with dry mouth, exacerbation of mucositis, ulcer, unable to eat, and so forth. Just last month, I had a patient from a suburb of Chicago, so the oncologist realized that was the problem was going on, said, showed everybody in the office that was graft versus host disease. She didn't do anything. She didn't call me. She didn't call a local BMT doc. She didn't treat the patient. She didn't do anything. So I think there is need for continuous relationship with the transplant center, in one way or the other, and the type of intervention and communication needs to be tailored. Obviously, if you are 500 miles away, you can't count a transplant center for everything. But there are lots of things that can be done just by picking up the phone and calling or sending an email.
I mean, for the first 100 days, we recommend our patients stay within a half hour of the center. Okay, and then thereafter, although there are some centers that give a little bit more leeway, and again, it depends on how easy it is to get to your center, based on that. Understanding driving through Atlanta traffic, I can see why even living 3 blocks down might be problematic. Probably be faster walking there than driving there, but that happens in issues, and that's something that has to be considered when you're going into this whole process. You're understanding that how comfortable are the doctors that you're dealing with now, currently, going to be with graft versus host disease and those signs or symptoms. If you miss a key sign or symptom, it could be deadly. And it's not to scare you away from the transplantation, but reality has to intervene here. So for the first 100 days, it depends on how far you live and your insurance company and the ability of having some sort of living facility nearby, and every center is a little bit different. You need to speak to the transplant team about that possibility. After that, then it becomes an issue of, do you need to be seen every day? Usually after 100 days, you don't need to be seen every day, but we ask that you go back to your doctors and be seen at least once a week, and that you get labs done, and if there are signs and symptoms and problems, you call. So it may require you to come every, if driving an hour once a week is too much, then maybe the transplant isn't for you. But if you can do that, some people do that around our center. They live in Orlando. It's about an hour away. They'll come to get their labs done here because they prefer to have it done and see us and connect with us every once in a while. So this is part of the understanding. It's not just getting in there and having that that sort of very distinct time period of the transplantation. This is the rest of your life. And as you can see here, 6 years, how many years out now? 19 years, and then some, that graft versus host disease can affect you for a long period of time, and you maybe have to deal with those. And understanding that it's not just get the transplant and be done with it. We really wish it was that easy, but it's not. By a show of hands here, how many of your primary care physicians or primary hematologists, oncologists have called the centers when there is an issue? So it's actually, we don't know. We don't know. So you may not know, but it doesn't seem like it's a majority of people that there's a good interaction for that. I think Dr. Anasetti can speak a little bit to more of some of those issues of hematologists, oncologists, and primary physicians, of their comfort level with graft versus host disease. And I mean, from the standpoint of the NMDP surveys and other things, you want to go into that a little bit, or how much is handled? I mean, basically, I think the biggest thing that scares the hematologist, oncologist is dealing with chronic graft versus host disease. It's not the leukemia, the lymphoma, the myeloma. It's the chronic graft versus host disease, and that's sometimes a deterrent of actually getting patients to transplantation. They feel that, you're not going to make it well because of my biases with this, and those are some of the issues here. But I think it's something that we need to do on our side of improving the communication. We know doctors' offices are very busy. They don't have time to call us, but some actually do take the time, or have myself or Dr. Anasetti on speed dial, and they do work well with us and call us frequently to say, hey, this is what's going on, this is what I want to do, and that's quite important. And part of your point is being a patient advocate for yourself is to say, hey, can you call them or call yourself the centers to make sure that these signs or symptoms are being taken care of.
I have a question, if I could ask you guys, Claudio, if you were going to address that. Can you tell the audience perhaps how large centers like Moffitt may help educate some of the community physicians, perhaps through symposia that you guys hold, or maybe you have standard practice guidelines that are available on a website? Obviously, there's really nothing that beats kind of, as you said, speed dial, direct communication. But are there ways that large centers actually try to educate to the best that you can some of the surrounding physicians, so that this gap in knowledge is not quite as notable?
Well, obviously that's matter of, on one end, it's matter of philosophy, but on the other end is matter of practicality. And chronic graft versus host disease, the other problems that we have after transplant, I think, are pretty well categorized. AVN, cataracts, restrictive lung disease, relapse. Those are issues that are common, unfortunately, still, both for autologous and allogeneic, but are well categorized. And usually any physician is actually able to tune in. But really, chronic graft versus host disease is a complex syndrome, and it's still, we're still working on validating the new NIH classification. The old criteria were just published in '79 on a series of 30 patients, never validated on any study. And so you realize, in the clinical trial, there were 2 or 3 clinical trials for chronic graft versus host disease. Most of them were negative. So there is really not been much advance in that area until actually a recent workshop facilitated by a number of societies in the NHLBI that really got a group of investigators to really nail down principles to diagnose graft versus host disease. But still, talking about treatment, there is the standard of care is supposed to be high-dose glucocorticoids. And in the way I practice now, that's absolutely a no-no. I basically don't use those drugs to treat that disease because I just think that goes backwards, cause a lot of problem and don't actually help the solution. The problem is that we don't. The best treatment for chronic graft-versus-host disease is not to have it. It's basically preventing it is the best thing, and so most of the efforts in this area have been directed towards prevention of graft-versus-host disease. Once you are dealing with one of the aspects of the syndrome, then the issue is not just management, but also diagnosis. Although now we have a very complex, it's probably 6-page long survey that is used to stage the disease. Many times, well, it's dry mouth because of past radiation, or it's dry mouth because of a of graft-versus-host disease, dry eyes because of Zika that preceded transplant, or it's just developed. And it's fatigue because the patient got chemotherapy, just like anybody else for cancer would, or it's because of this insidious syndrome. So it's so complex that for me, sitting down with the patient, I cannot even rely upon my nurse, physician assistant, or resident or fellow that's seeing the patient. I just need to have a one-to-one contact to actually assess whether there is syndrome activity and whether the level of activity is high enough that requires intervention. Because every time we make an intervention, we create risk. So there is risk from disease, but every time we change therapy, the risk goes way up. So that can be a beneficial thing, but it could be causing side effects. So in an area where an understanding of the disease is just beginning, the diagnosis is still extremely problematic. The treatment is really, the standard treatment, in my view, is just an aberration. It just doesn't work well and causes an enormous amount of side effects. Educating on all this, basically 600 referring physicians in Florida from about 10 transplant docs or 20 considering everybody else, in my view, is just unfeasible. So it's possible that things will change. Transplant is up to about 15% of hematology board exam questions. But you know how many months of experience a hematology has to do in transplant before being a certified hematologist? What would you say? 2 months? What else would you say? 3? Okay. What about oncologists? How many months an oncologist would have to do BMT in order to become certified? 2-3 months for an oncologist, 2 for a hematologist. The answer is 1 for a hematologist, 0 for an oncologist. So now, these docs may have not have seen transplant patients except for 1 month, where usually they see patients in a hospital setting, perhaps in a clinic, and really don't understand much of anything that's going on because it's too short of a time to actually even get oriented. And then later on, we got to actually teach them how to recognize a syndrome, and we ourselves have problem boxing it in. So I think my undesirable answer to your question is actually that's a hopeless task. Right. So, I think that Hugo mentioned that Hutchin put together a wonderful packet for referring docs that had a pretty lot of details. I have worked in long-term clinic where we actually had correspondence with the referring doctor. We're all over the United States. I moved away for about 7.5 years, but I've done that work for a while. And my view is that, even telling people that just doesn't actually reach the mark. The stakes are so high and the situation is so complex that in my view what is going to pay better is actually educate the patient. because the focus is direct. I don't have to educate 600 oncologists that are going to see perhaps one BMT patient per year. I have to educate a patient that has a stake of life and actually knowing what exactly needs to do is in front of me and needs high-level education on all the key aspects that actually needs to watch. And obviously, a transplant nurse has an enormous stake and a load on doing that type of education, and the physician has to tailor that education towards key points that actually have to be looked at. Charlie, can you tell us a little bit from your point of view, going through with Kathy through? You are the spokesperson for Kathy, right? Okay, so
tough decisions, yes. And this is, I think, coming out here that I think the safety net out there is maybe not so good, but we need to work on that, and we need to work on educating you. And part of the reason for the survey is we need to know how to do this better. Please write your questions and comments on the back of that paper. The more you give us, the more we can work with and maybe know how to attack this elephant, starting at the trunk or the tail. We don't know. Yes, sir. Absolutely. And we do that when patients relocate. I do that in particular when patients relocate. I try to have them find the closest center to them. I've had people go up into the Carolinas. I have them either go to Duke, or if they go into Virginia, the University of West Virginia, there's places around. You need to find something that if it's 3 hours away from your transplant center, maybe an hour away from another transplant center. And we accept patients from other transplant centers that relocate all the time. It's a matter of communication, and we'll take it over. And you know, transplanters to transplanter are more apt to talk than other folks. So I think it's absolutely necessary. Where's he living right now? Orlando. Well, you're right down the alley. There is a center in Orlando. There's also a center in Tampa there. That's only an hour away. So you'd be more than welcome to see him. All right. Thank you all for your time, your comments, and your participation.